So I'd like to really thank our panelists. We have Johan Maritz from CSA&G, which we are very grateful to have. We have Vuyisa from CSA&G and Just Leaders, who are also grateful to have here. And then we also have Shari from Activate WITS. And we're just really grateful to have all of you here to speak to us, for you guys to share your time with us. Johan has prepared a presentation on a new report that came out on queer sexual health. So without further ado, let us start with that.
Thank you. Hi, everyone. As Michaela said, I'm with the CSA&G here at UP, and our vision is to understand power, explore diversity, and examine difference and imagine inclusivity. And I hope to have an honest and frank discussion with you in an affirming, non-judgmental, and sex-positive manner. And I try to be aware of my own positionality as a cis white gay male. My pronouns are he, him, and his. Despite the title, I'm going to focus on queer sexual health. And I know the other speakers will touch on some of the other things too. My presentation is not going to be provide all of the answers on queer sexual health, and nor is it the final word on queer sexual health. It's just a snippet of what is out there. So I thought as a background, to understand access to queer sexual health services and all that, we need to say and acknowledge that we've got an enabling constitution and a legislative framework. The South African Constitution offers comprehensive recognition and legal protection to LGBTI people. The state is obliged to respect, promote, protect, and fulfill the rights enshrined in the Bill of Rights. Central to the Bill of Rights is the Equality Clause in Section 9, Paragraph 3, which mandates that nobody may be discriminated against based on, among other grounds, their sex, gender, or sexual orientation. Section 10 guarantees that everyone has an inherent dignity and the right to have their dignity respected and protected. And further rights enumerated in the Bill of Rights include the right to life in Section 11, as well as the right to security of the person, including the right to be free from all forms of violence from either public or private sources, the right to security and control over their body. The right not to be treated or punished in a cruel or inhumane or degrading way, Section 12, as well as the right to access to healthcare, Section 27. These constitutional commitments and legal reforms exist amidst staunchly conservative societal attitudes which manifest in social exclusion, discrimination, and violence in the daily lives of LGBTI people, including healthcare. And understanding our bodies and the tools that we were given to have sex with can be challenging to many, if not most of us, at some point in our lives. And bad or a complete lack of a comprehensive or honest, truthful, and judgment-free sex and sexualities education, limited access to appropriate information and services, poor understanding of linkages between mental health and sexual health. Times have changed, but stigma still prevails and other barriers are still present. And self-stigma is something we shouldn't forget about. And it could be about who we are or what we do sexually can be a major barrier to sexual health. So I thought of, to understand, the first thing for me about sexual health is, let's put all of the cards on the table and say, you know what, all bodies are good bodies. They aren't bad bodies, or all bodies are good. Do research about sexual health, things you worry about, things that you wonder if it's normal. In my years of working with young people and with university students, is they're constantly worried about, but is this normal? How do I measure up, or am I different, and all of that. Sexual health is about pleasure too. It's sometimes so over medicalized and all of that. Remember, sex is about pleasure. It's about fulfillment. It's about reward. But similarly, mental health is part of the full self, and that's part of sexual health. And you need to understand, what are your boundaries when it comes to sex, physically and emotionally? Do you have any limitations when it comes to sex? Are they temporary limitations or permanent in nature? Self-pleasure is self-care, if you choose to. So that's a way of getting to know yourself and your body and the whole you. When we know ourselves and our bodies, we are likely to know sooner if something is amiss or wrong. So when we opt to have sex with others, for me, what's included in sexual health is personal safety first. You know, where you have sex, under which circumstances you have sex, that is all part of sexual health and sexual well-being. Only when you are ready, consent is mandatory. You know, it can take, the circumstances can be serious or casual, with someone you love or not. It's not a prerequisite. But remember, relationships does not equal sex. Sex does not equal love. Love does not equal common sense. And it doesn't equal wholeness. You don't need another person to complete you in any way whatsoever. So, talking about consent, consent can be sexy. You know, it does not need to kill the vibe. In fact, it sets the right tone for a healthy relationship or sexual encounter. It will make you a better partner and can boost your confidence that your partner also wants you. Relationships built on sexual consent often grow to have strong roots of trust. Silence does not mean consent. Consent is not assumed or hesitant. Consent is clear and understood by everybody involved. How do you know if there is consent? Simply ask. Be honest with yourself and your partner to make sure there are no doubts or discomfort. You can change your mind at any time. Sexual activity should feel right every time. Just because you did something once before does not mean you need to be okay with it again. Similarly, you can also withdraw consent during sex. It is yours, you know, it's a different version of the withdrawal method. As you know, withdraw your consent and say, you know, no, this is not working for me, or I'm not feeling safe, or I'm not enjoying this. So, no one can consent after using drugs, alcohol, or any substances. If someone is buzzed, high, or blacked out, they cannot give consent. A lack of resistance is not permission to continue. If someone is motionless, they do not have a voice to agree or disagree. Using force or control or threats is never okay. Check in with yourself and your partner by asking questions. Communicate. I'll touch on this later about sexual communication as part of sexual health. You cannot change the terms of the agreement of the consent. If you agree to use condoms and you remove the condom without the knowledge and agreement of the other partner, it amounts to sexual assault. Some people refer to that practice as stealthing, for instance. No means no. I don't know does not mean yes. Yes means yes. Saying or hearing no may not always feel great, but respect is important in any relationship or encounter. But if we're talking about sexual health, you know, and the range of services and things, what are the different things that cisgender women, you know, need to look into, or what services do they have a need for? Family planning and contraception, if applicable. You know, breast cancer checkups, mammograms, STI counseling and screening, HIV counseling and screening. There are hepatitis vaccines available. There are HPV vaccines available. There's also a rollout now with HPV vaccines in schools for young girls. General checkups, cervical cancer screening, pre-exposure prophylaxis. PrEP is available in South Africa. It is very effective. Something that is often overlooked or left off of lists is termination of pregnancy. You know, it's a right, it's enshrined, you know, within the Constitution, that women can choose when and how they have children. And mental health and psychosocial support, you know, either through a professional, also through UP&Out support group. That's a form of psychosocial support. What are the typical services required for cisgender men? Is STI counseling and screening, HIV counseling and testing, hepatitis vaccines, HPV for men as well. Some men are at higher risk for it. General checkups, testicular cancer checkups, prostate cancer checkups, normally later in life. Voluntary medical male circumcision. It has been touted for many years as a means to prevent HIV infection. But within the context of, there's an arsenal of things to protect us against HIV. So if it isn't for you, there are other options available to you. Pre-exposure prophylaxis, and men are often bad at mental health. So it is essential there. But if we are talking about sexual health for trans women, the picture changes a bit. Sexual health is part of being human. Like anyone else, as a transgender woman, you want to feel great about your body. You want to have sex that is safe, feels good, and is rewarding. But remember, each trans woman is unique. You may or may not have had surgery. You may or may not take hormones. What you like to do when you have sex is unique to you. Surgery, it is healthy. If you hadn't had surgery, it's healthy and normal to use your penis for sex. You should know that to keep an erection, you need some testosterone in your body. If you are taking female hormones, it might be harder to keep an erection. Ask your healthcare provider what hormone doses are right for you. Keep in mind, when you take a low dose of female hormones, the changes you may want may take longer. As a trans woman, you still are still at risk of STIs, and you need that to be screened for it. But what about your fertility? Trans women who take hormones may still have enough sperm to cause pregnancy. Use birth control methods that if you do not want to have a baby. If you want to have your own child in future, it's good to plan ahead. You may have to go off hormones to produce enough sperm. You could also put your sperm in a sperm bank before you start taking your hormones, which you can then able to use with your partner when you want to have children. Breast health, if you take hormones, your breast will start to grow. Talk to your healthcare provider about what to expect. Anyone can get breast cancer. Tell your healthcare provider about any family history of breast cancer, and let your healthcare provider know if you have breast pain, lumps, or any other changes that worry you. What about pumping? Pumping, some trans women have silicone injected or pumped to get the curvy body that they want. Large round breasts, hips, thighs. But pumping can have serious health problems. The injected products may harden, cause pain, and travel to other parts of the body. This can lead to infection and make permanent and unwanted body changes. Many women have died from pumping. Talk to a trained healthcare provider about safe ways to get the body you want. Do not do it on your own. What about tucking? Tucking is a way some trans women use to hide their genitals beneath their clothing. The idea is to gently push the testicles up inside the body and to pull the penis back between the legs. It is held in place with tight-fitting underwear or surgical tape. Here are some things that you can do. You only use surgical tape. Other types of tape could peel off the skin when removed. Cut the hair very short in the groin area. This makes it easier to remove the tape. Spend some time daily without tucking. Tucking for too long can cause health problems. It can cause chafing and sores. It can also lower sperm count. Keep this in mind if you are trying to have a child. But for trans men, again, it's a different picture. But similar to trans women, it is part of being human. You may or may not have had surgery. You may or may not be taking hormones. And what you do during sex is unique to you. But what about your chest health? If you've ever had your chest redone, you may still be at risk of cancer. Talk with a healthcare provider about getting chest health screenings and mammograms. Tell a healthcare professional about any family history of breast cancer. STIs, trans men are still vulnerable to STIs, and there are ways to reduce their risk. But what if you are taking hormones as a trans man? Taking testosterone will often cause your periods to stop in between 1 and 6 months. You may get cramps during or after an orgasm. If you have this pain often, talk to your healthcare professional. Testosterone can also thin the walls of the vagina. You could use a low-dose estrogen cream inside the vagina to keep it from thinning too much. This will help the vagina from bleeding if you choose to have vaginal sex, which lowers the chances of getting an STI, especially HIV. The health of the cervix. Trans men are still at risk of cancer of the cervix, uterus, and ovaries if they still have these parts. So they need to be checked out. A pelvic exam. If you've not had surgery, you still need to continue with your pelvic exams. Can I still fall pregnant? Some trans men have had surgery to remove the uterus and ovaries. These trans men cannot get pregnant. If you still have a uterus and ovaries, you can still get pregnant even if you take testosterone. So birth control is still advised. If you want to get pregnant, you'll need to stop taking testosterone if you want to fall pregnant. High levels of testosterone in your body during pregnancy can cause birth defects in the baby. Talk to your healthcare provider if you're trying to get pregnant. But what about chest binding? I've prepared a whole slide for it because it's interesting. There are specific guidelines around chest binding during COVID-19. The trans and non-binary people who bind their chest are at a high risk of complications from COVID-19 if they get infected, especially if they have asthma or another respiratory illness. If you have a cough, it's recommended that you avoid binding, as it can cause a buildup of fluid inside the lungs. Stop binding if you're feeling sick. If you feel it's not possible, consider wearing a warm binder sparingly, not too tight or just a tight shirt, under your other clothes. Once your binder is off and make time where you are not binding, remember to cough, as this will help loosen your upper body and expand your lungs to their full capacity. If you are ill or have some kind of an infection, extended periods of binding can also cause skeletal pain, muscle pain. So do make time when you are not binding too. So if we are talking about access to services for LGBTI or queer people, historically, before 1994, there was basically nothing. It was illegal to be us back then. But there were informal networks of people, you identify a queer doctor or a queer health provider or allies and LGBTI-friendly service providers, and people shared that information. But in the broader public sector, there wasn't really anything available. With the advent of the HIV epidemic in South Africa in the 80s, nurses at the Steve Biko, then HF Root Hospital, refused to provide care to HIV-positive patients. And teams of queer volunteers provided the care in their stead. Initial services post-1994 were very limited, and most of them were born out of HIV programs. But this and the labeling of gay men and later men who have sex with men as a key population exacerbated stigma and homophobia. But one of the advantages of being a key population is it means that we now get access to free PrEP because the key populations get free access to it. But a lot has changed. Many of these services listed in the previous slides that people need or that's recommended are not available in the public sector. And I mean, I can ask, the question is, are they available on campus at student health? And I think almost with a resounding, I almost just say no, they're not available. Some of the services referrals are available, but some of them are just not available. At times, more services are available. I know recently there were free pap smears available for women again through student health, which you could access. But what often happens is the gap is filled by the non-governmental organizations or the NGO sector. And just, you know, 3 examples. We've got a very good one in Pretoria, you know, Out Wellbeing. They've been around for probably about 26 years. I saw my colleague Pierre was in here earlier. I think he was one of the founding members back in the day. Of that, there's the Triangle Project in Cape Town. There's, you know, We the Brave that are based in Johannesburg, but they also operate nationally. But NGOs have also made great strides in sensitizing healthcare workers about queer matters, our sexual health needs, you know, and providing more gender affirming healthcare. But I would regard that as work in progress. I think, you know, we can just reflect on our own experiences on campus and say, you know, how open are you about who you are and what you do when you go and see a healthcare provider? So access is still a major challenge, but specifically around mental health. And, you know, it's important to note that trans and other services were severely disrupted by COVID-19. There were several drug shortages, specifically hormone treatments for trans people who had to stop their hormone therapy at stages during the COVID epidemic because it wasn't available. But also part of our sexual health is also our sexual fitness. You know, sex and food, what we eat is important, nutrition is important, what we drink is important. We require fluids to have sex. To live, we need fluids. It does become problematic that, you know, if the fluids that we're taking are alcohol, alcohol increases your desire, but it decreases your performance. You know, men sometimes have got problems keeping an erection or getting an erection if they've consumed too much alcohol. But similarly, weight and sex, if you are severely overweight, you are at more risk of heart disease, diabetes, and high blood pressure. All of these affect the capacity of a person to have erections. If a man has a lot of fat around his middle, he'll produce more female hormone. We can cause problems with erections and even make him impotent, unable to have an erection at all. So a bit of exercise helps. Even if that exercise is sex, it probably also helps. So smoking also affects your performance. Stress can affect your performance, and drugs can affect our performance, whether it's prescription drugs, you know, whether it's blood pressure drugs. Some antidepressants can severely affect your libido. You know, you're just not interested in sex, or you know, you're just not feeling it. And there are other drugs which can also improve your performance or help you get an erection, whether it's Cialis or Viagra, etc., etc. Sexual communication: say yes to what you want and no what you don't. Non-verbal communication: read your partner and provide them with non-verbal cues so that they can read you. Talk with partners about sex to increase sexual safety and informed decision-making. Increase comfort and it increases comfort and intimacy, and extend sexual communication outside intimate situations. Talk about your needs, wants, desires, and all of that before you're in the moment. Just a few words. Safer sex: it should be fun and sexy. It doesn't need to be boring. It is about physical safety too. It's aided by sexual communication. Fears about HIV and STIs can be debilitating, or be a barrier to enjoying having sex. Knowing how to reduce your risk is liberating, and it builds confidence. So you need to understand your risk profile. You know, if you've had previous unsafe sex, if you've had multiple partners, if you've previously had an STI, if you've ever shared needles, or if you've ever exchanged sex for drugs or money. If yes to any of those, then you are considered at risk, and you know, you need to access some of these services to determine your status. But there are many ways to reduce your risks. You know, know your HIV status. We provide free testing and counseling. Know your sexual boundaries and communicate them to your partner. Male or female condoms for anal and vaginal intercourse with a penis or a dildo or other sex toys, depending on the partners involved. Lube is your friend. During anal penetration, it's almost as important as consent. Dental dams for cunnilingus or anilingus. There's a picture of a dental dam over somebody's mouth. And, you know, there are lesser known things like finger cuts. If you've got, you know, using your hands during sex and all of that, for anal or vaginal penetration, you know, you might have cuts, skin abrasions, all of that. A finger cut or a latex gloves will protect you. PrEP is effective in the prevention of HIV, and people on PrEP often stop using other barrier methods. You know, that's how effective it is. When a person has HIV, they're on treatment and their viral loads are undetectable. They are regarded or deemed uninfectious. So that decreases the risk profile. But it's important to note that people on PrEP are not promiscuous, but are actually taking responsibility for their sexual health. A few brief notes on condoms. It's not bad to carry condoms. Be prepared. Make sure your condoms are fresh, not expired or damaged. The condom in your wallet from your first year will probably not be advisable to use in your honors year. When you finally get there, though it's dead easy to use a condom, it can easily become rocket science if you're drunk or you prefer to keep the lights off. Practice makes perfect. Putting on condoms on yourself or your partner. Some people can be allergic to latex, but there are alternatives available. I do say here, female condoms are an alternative, but the current female condoms are no longer polyurethane condoms. They're also latex condoms. And non-latex condoms can be pricey, so it's an issue of access. You need to be flush with cash to buy the non-latex condoms. Lube will spice up your sex life, and in some cases it's essential. Some vaginas are naturally dry, and it's always advisable for anal sex. Only condoms, safe lubes, no Vaseline or hand creams. But part of our safety in our day and age, and especially during COVID-19 now, is online safety. You know, if you're planning to hook up with somebody, you know, check out their story, do a little digging, see if they are who they claim to be. Do an image search. Google has got an image search function. It might just, you know, their profile pic might be an image they found in an image bank somewhere. There's apps that you can install on your phone like Truecaller. It can help you to identify, you know, you now have a number, and now you can determine the true owner or identity of that number. Some people are dodgy and you don't find their numbers through Truecaller or similar apps, or they use online Google voice call numbers instead of their own cell numbers. Take it slow, meet in real life, inform a close contact when we are meeting someone, all the details, who, when, where, etc. Try not to share intimate photos. Most of these recommendations say do not share intimate photos. I'm not here to tell you what not to do, but if you do, and this is advice from a lawyer actually, exclude your face from any photos showing your intimate bits. You know, don't show your face and your intimate bits in the same picture. Blackmail is rife. People exploit it. They figure out your identity, and then they say, well, unless you give me 5,000 rand, I'm going to send this to your mother or your partner or whatever it might be. Never send money. That's a good principle. I'm almost done. So the last thing as part of sexual health is, you know, intimate partner violence or sexual and gender-based violence in the queer or amongst queer folk. LGBTI people are not more violent or more prone to violence or more likely to be violent than other identity groups. People of all identities perpetuate and experience intimate partner violence, but LGBT folks are disproportionately victims of intimate partner violence by other LGBTI people and non-LGBTI people. Trans people are at a disproportionately higher risk of intimate partner violence and sexual and gender-based violence. Intimate partner violence can be sexual, physical, emotional, economical. It can involve isolation, threats, and intimidation. Some of us might be in a relationship and we might still be deeply in the closet. a partner threatening to out you, that is a form of intimate partner violence. Places of safety seldomly cater for LGBTI people. So currently South Africa has got a single queer shelter in Cape Town. There's one that's being planned for Johannesburg, but they've been planning for 2 years and there's still nothing, so there aren't many places of safety for LGBTI people. So we often need to take care of our own within our own formal and informal networks. If you are a victim of intimate partner violence or sexual and gender-based violence, contact us. We can offer you support and see how we can assist. But what do you do at UP? If you're denied services or have a bad experience when you access services, and it's based on your gender identity. But it's now more than a year later. We've got a comprehensive anti-discrimination policy, and it says, mindful of its past and taking cognizance of the vision and mission and underlying values enshrined in the University of Pretoria strategic plan, the university seeks to build an inclusive, affirming and transformed institutional culture, curriculum and campus and residence life. The custodian of this policy is the Institutional Transformation Office, which is also based at the CSA&G. The aim of this policy is to promote the achievement of procedural and substantive equality, to prevent the following actions being taken by UP staff members, students, and third parties, and to provide support and remedies where they occur: unfair discrimination, hate speech, speech harassment, and violence. So your first point of call could be security services, your head of house, Department of Student Affairs, the SRC, the head of an academic department, deans, etc. So anybody in an office or any office bearer and appointed authority can be your first point of contact. They are obliged to assist you. You're free to contact the CSA&G for assistance or referral where it's required, or you could go to the Transformation Office directly, as they will be investigating your case if you choose to open one. It's good to report it. It's good to take steps, but it should still be about you. You should feel comfortable doing it. The Transformation Office and the CSA&G is also assisted by Speak Out UP, our volunteers who are trained in basic counselling skills, who's almost like emotional first aid, to help you through the different steps and things. The LGBTIQ A++, there are so many groups that make up our community. So it was impossible for me to give a comprehensive thing for everybody about sexual health. It might be useful at some point to focus on a single letter at a time in any of the UP&Out support groups. I'm happy to assist where I can, or get other people also involved for all of the letters or groupings and things. You're free to contact me, and the center contact details are social media, but then also our social justice volunteer program, Just Leaders. We are in our newly refurbished building, which is now also the home of UP&Out. They will be based here. So hopefully one day everybody will be back on campus. You can find us here. We offer walk-in services. Also, the entire building has now got gender-neutral bathrooms, universally accessible for people in wheelchairs, and also with Muslim facilities. That's it from me.
Thank you so much, Johan. I think that was a really awesome overview to queer health and queer sexual health, and just sort of an introduction to our topic, and sort of giving everyone a really sort of comprehensive look at like what as queer people we should be worried about and should think about before entering into sexual relationships and sexual partnerships. So our next section's more of a discussion, so we're just gonna volley back and forth between the panelists. So what I wanted to start with was just maybe sort of icebreaker Vuyisa, if we could start with you and then Shari can follow. If you could add or remove one thing from the current sexual education curriculum as a part of like schools and universities, what would it be?
I think the one thing that I would remove is I want to pronounce this word correctly, the pertinent, the where educators and the university act as parents, where we want to control or dominate how sexual education is rolled out, where we don't view learners and students as having agency, because we need to realize that learners and students have agency. They have the right to decide and have the control over their own bodies. I think that is what we also need to acknowledge when we're rolling out sexual education.
And that's awesome. And Shari?
I was going to say the same thing, but one thing I'd change is, I don't know, the shame that's associated with sexual education. Because like when I was taught sexual education, it was taught to me when you have sex, these are all the bad things that are going to happen if you have sex.
Yeah.
You'll get pregnant and you'll get STDs, and that's like it. So I think when we teach sexual education, I wish we taught it in a way where we didn't shame people for being sexually active. And I feel like also people, because sexual education is mostly spoken to, like it's mostly taught to teenagers. And I just feel like it's very weird because, like Vuyisa said, we teach it in a way where like people don't have agency, like it's not a choice at the end of the day, it's just something they are gonna do because of their hormones. So it's like, I just wish that shame was not there. Yeah.
And Johan?
I can probably give you a whole shopping list, but I'll keep it short. I mean, I think first of all, I would like there to be a comprehensive sexualities education, because often there isn't, and when it is there, like Shari said, it's over pathologized. It's about illness, it's about risk. It's not about pleasure. We need an honesty about it. It needs to be factual. And what I would remove is any sort of reference or programs I think that should be banned is values-based or morality-based sex education, because it's often just, whose values, whose definition of morality, yeah, I'll leave it there. Yeah.
Okay, so the things that is often missing from sex education in general. I mean, if, like Shari said, sex ed is mostly taught to teenagers. I mean, like when I was in high school, like she said, I got like very shame-based education. It was like, you shouldn't have sex, but if you have sex, use a condom, and there are STDs that from a video in the 80s that they showed you about how horrible STDs looked. And you're going to get pregnant, like type thing. So I just wanted to touch quickly on the very cis heteronormative construct of virginity and the way in which we talk or even don't talk about queer sex in the general like populace, and just your thoughts on that, and in ways that like I have lost my words. Just Shari, if we could start with you on I know as queer women there is often like, you're still a virgin because like there is no penis involved, and it's this weird construct in which queer women are taught that the way in which they experience sexual pleasure is not sex. So I just wanted your opinion and maybe thoughts on that. So
because I actually wanted to speak about how, you know, damaging this notion that sex is centered around the penis. So like this very patriarchal notion that like sex is penis in vagina and that's it. Like, and I feel, and I'm so glad you brought it up because there's so many moments when I've talking about my sexual experiences whether and because quite a few of my sexual experiences have been without, you know, a penis, if I could say that. And a lot of people, whenever I speak about it, a lot of people are like, then it's not sex. And I'm like, what are you talking about? And they're like, if there was no penis, then there's no sex. And I'm like, and I think that's so damaging because yes, it invalidates a lot of queer people's experiences, but also it creates a monolithic idea of what sex should be. And it's actually a very shameful thing because when I was in high school, a lot of my friends at the time didn't understand how lesbian women would have sex. They'd be like, how would it work without a penis? And would be like, that's that's not it. And I agree with the fact that it invalidates a lot of queer people's experiences, but it also just creates this very toxic idea of heterosexual sex as well. Because at the end of the day, a lot of women, whether it's queer or straight, don't know how to pleasure themselves because they think the only way to pleasure themselves is with a penis, which is so unfortunate because it's like there's so many ways to have fun sexual experiences safely and consensually, but you don't need a penis to be involved. You know what I mean? And I think it's a very hard conversation because a lot of women don't know how to self-explore their pleasure because that's what they taught sex is. It's just a penis in a vagina. And it's just very tough as a queer community because when you taught that from a very young age, especially in high school, then it becomes a very hard conversation to have with future sexual partners. Like, how do we explore sexual pleasure together? How do we explore sex when both of us are a woman? You know what I mean? I only learned from the internet when I was out of high school. And then I was like, oh, this is possible, you know? And I was like, oh. And it's like, and that's so upsetting that I had to learn from the internet rather than learning from a place I went to 5 days a week. You know, it was just tough. And especially because I took the agency and I took the initiative to do the research. A lot of people don't have the spaces to do that research, but a lot of people also don't know how to do that research. Like because of that shame and stigma around sex, but especially queer sex. So like, yeah, it's very unfortunate that a lot of women just don't orgasm or don't have pleasure in sex because just of that initial idea that it's straight penetration and nothing else. Yeah.
yeah, I mean, I know of people who have friends of friends and who have so much shame. Like a lot of women loving women sex and queer female sex is centered around is not really centered, can be centered around toys, but is often oral. And
yeah.
I know so many straight women who are like, oh, but I don't want him down there. Like, I don't want him to see that. Like this sense of almost shame and disgust around their own genitals that society has taught women to be shameful of, which is just so sad. So I definitely get where you're coming from on that. Vuyisa, I wanted to ask you, if you talk about Johan touched on this a little bit, but the stigma of STIs and the idea of being clean or so-called cleanliness that is associated with being STI free. Just on like roots and how do you think that where we can go to destigmatize STIs and teach sexual health in a way that is both, like Johan said, factual and accurate, but compassionate and empathetic, and that does not shame people?
I think for me, the starting point would be understanding why do we stigmatize when we talk about STIs, HIV and AIDS. Why is it that with those illnesses there is so much stigma attached to it? And when I read the work of Peter Algerton and Richard Parker, they offer us a very interesting lens in terms of understanding our conceptualizations of stigma. And I think this is very important as we move forward in terms of changing our attitudes, changing our conceptualization and understanding of disease and illness. And in their work, and largely even in the work surrounding stigma and discrimination around HIV and AIDS, as well as the LGBTI community, they root this work in Eric Goffman's understanding of stigma. And Eric Goffman defines stigma as an attribute that is significantly discrediting, which in the eyes of society serves to reduce the person who possesses it. So I think that is also very interesting to have that understanding. However, Peter Algerton then tells us that even in research around HIV and AIDS and STIs, a lot of that work in terms of understanding stigma and discrimination has been rooted on individuals, where we pay attention to those who stigmatize and to those who are stigmatized. And as much as that research has been helpful, it is very limiting because he invites us to think of stigma and discrimination as creating exclusion amongst people, as stigma and discrimination as it being about difference and deviance, that this notion of stigma and discrimination is not seen as something that is it's not seen as something that is mapped onto certain bodies. Because that is what stigma and discrimination is. Society maps these identities or these things onto people, and he is inviting us to think of another way to conceptualize stigma and discrimination, and rather look at the structural issues or structural dimensions of stigma and discrimination. So I think to answer your question, it is really important that our starting point is to understand how stigma is conceptualized, how we use it, how we label people, and how we attach these labels onto people, and how stigma really is an issue of, at the root of stigma and discrimination, it is about domination and power. And we see in terms of how services are rolled out. I mean, in Johan's presentation, and even in what Sherry had contributed, it is not by accident that we have these health disparities when we are talking about STIs, HIV and AIDS, and queer communities, that certain groups and certain bodies do not receive the adequate health care. It is because these structures, it is because of control and domination, and the way in which healthcare is rolled out, or the ways in which it invisibilizes certain bodies. It is against the institutionalization and the reproducing of stigma and discrimination.
Wow, that's really profound. Thank you. I just sort of like to touch on part of what you said. bit more from maybe a sort of anecdotal perspective, when we talk about structural changes and the fact that people are left out of, queer people are often left out of the conversation. I know I'm a young queer woman. I have to go to the doctor who is on my medical aid program because otherwise I have to pay 500 Rand a consultation, which is not really affordable when you're a student having to see a GP for whatever reason. And whenever I go to this GP in Pretoria with the flu, his comment to me is always, "You must stop kissing all the boys." I've had HIV tests at pharmaceutical retailers where the practitioner told me I was positive as a joke, to say, "Oh, at least you'll be careful now." Yeah.
Wow.
Which is not fun, which is not fair, which is like didn't even think. But like, if you talk about the conversations in which stigma and HIV exist, and the conversations in which we can relate that to queer-friendly healthcare practitioners, and the inclusivity in which healthcare practitioners often impose their own opinions and views on queer people and queer healthcare, where do you see that moving and growing in the future?
That's a wow. That's a very good question. And I think the starting point for me would be, again, a historical understanding of what gender and sexualities is. Because oftentimes we are ignorant of understanding how we have become gendered persons, and how it has been that heteronormativity has become, or heterosexuality has become, the dominant or the normal way of being. And I think it starts with dismantling that understanding of gender and heterosexualities, because I think once we start there, we can start forming communities of resistance, and what Peter Algerton would refer to as identity project identities, where we reject being told or how to perform our genders, or how to be in the world, and rather form or rather mobilize communities who will say, I reject how society wants me to be, and how society wants me to practice my gender or sexuality, so that we form new ways of beings. We begin to redefine what gender and sexualities is. And for me, the queer community is a very interesting community to look at, because I feel like you have led the way, and that there is so much that as heterosexual identifying beings that we can learn from you, because you have rejected dominant narratives of how to be in this world. So I think that is the starting point in us understanding how it has come to be that heteronormativity or heterosexuality has become to be the dominant way of practicing heterosexuality. So I think that awareness and that unlearning is very important.
Wow, okay, awesome. Johan, I just wanted to know if you had any thoughts or opinions on like sort of the stigma that healthcare professionals place on queer people themselves, and where you see that moving, similar to the way I phrased it to Vusi, and your perspective on moving forward towards a more inclusive, queer-friendly care?
I'll reflect on or sort of share two experiences about it. I think, first of all, when it comes to fostering gender-affirming healthcare and access to gender-affirming healthcare, there are several initiatives going on. About NGOs, the Department of Health has also commissioned organizations to do training for their staff. I do feel that I think at times the people conducting these sensitization workshops, or sometimes they're not the remedy, they actually continue some of the stereotypes and all of that, because the approach, I don't think it's always intersectional enough. I mean, we had an experience in the center where university health staff were trained on youth-friendly services, but the training was homophobic.
Yeah.
So, there's no intersection between oppression and all of that. And I do think, because of the continuing homophobia and stigma and all of that, I think there's sometimes, they want to pathologize the queer community. A lot of the services we need are often health related. But don't pathologize us. Don't see us as that disease. The second story was at a national meeting of student healthcare providers. I had a conversation with a few nurses, and we spoke about inclusive healthcare services. And the one older nurse, she just said, well, we don't need all of these trainings and all of that. I mean, we care for everybody. A penis is a penis and a vagina is a vagina. And she, that embodied their approach to healthcare. They remove the person, the identity, your life story. You're just a penis or a vagina, but I can guarantee you, if the owner of that penis has got breasts too, it's going to be problematic for the healthcare for that specific nurse. And there's an unwillingness to unlearn, as Vuyisa said, and we need to demand, and I do think there is a willingness within the public healthcare sector to make services more accessible, and we need to find and build relationships and co-create the spaces that we want and the spaces that serve our needs. In some sections, some of the newer research in the report that you refer to as well is some people prefer to access these services from an LGBTI care provider. Those are available through NGOs. Out Wellbeing in Pretoria, they offer comprehensive services for the queer community. PrEP, they've got sessional doctors, they've got nurses. You can access what you need, and the gender-affirming care that you need is available fairly close to campus here at the University of Pretoria. We can put you in touch with them if that works for you. Other people or members of our community prefer to access mainstream services, and they sometimes some clinics have got champions in them which are more progressive. But yeah, I mean, talk with members of the community, see where people are accessing services. Also, if you've accessed good services, share your experiences with your peers or other members of UP&Out. So you know what, that doctor at HatMed, ask for that GP if you have to go to HatMed, because they really know their stuff. Or they made no assumptions about who I sleep with.
Shari, I wanted to ask you, as a young queer woman, what do you think are the current steps that could be taken for a more inclusive healthcare for queer people? current steps?
Current steps. Ooh. I think the first step, like Vuyisa said, would be to deconstruct ideas of sex and gender. I think that is the first step that we need in terms of healthcare systems, because it's so frustrating when I go to like a clinic or something, like recently for going for like a checkup, like a pap smear or something, and the two options on the sheet are always male and female. And it's very tough because it's like, I don't conform to either of those boxes. And even if there was, I just wish there was more, identification for the queer community in terms of in terms of like sheets, in terms of safety, because then it's like, if I don't take male or female, then how are they going to treat me differently? You know what I'm saying? It's like, am I safe in this space or whatever? And then another step is, I think we need to relearn what consent is. I feel like that's a big thing, especially within the queer community, because, and all like also with the heterosexual community, because I feel like a lot of the time people assume consent is only about physical safety. And I think especially with like schools fall short in terms of talking about consent, they forget to talk about how consent is not only about physical safety, but also emotional and mental safety, because sex is just as much mental as it is physical. So I know a lot of situations where a lot of queer people I know have been in unsafe situations. Even if it wasn't physical, the person wasn't being forceful, but the person having sex just didn't feel safe, saying, I'm not in the mental space to have sex. I'm not in the emotional space to have sex. And then it creates ideas of like, did they rape me? Did they still sexually harass me? And it just creates very hard lines about what consent is and what sexual assault is. So I think in terms of safety, in terms of healthcare, we also just need to reteach what consent is. But in terms of healthcare as well, I think it also just lies in diseases. Like we've said before, obviously I'm not an expert in the healthcare system, but just in terms of my experiences, like I've also gotten HIV tests, I've also gotten, HPV and STI tests, and how it's just very uncomfortable for me when I go to these when I go into these certain situations. And like you said, Michaela, they always assume my partner is a man. B, and B, it's always assumed that whenever HIV is spoken about outside of these spaces, it's always still seen as like this gay disease. You know what I mean? It's the disease of like the queer community. And so a lot of people are ashamed to come out when they say, or they don't have to obviously, but to say, I have HIV and AIDS. And a lot of people, especially men, are ashamed to talk about it, because then people assume that they queer. And even if people assume it, it's like, what's wrong with being queer? What's wrong with being part of the queer community? So I think it's very hard in terms of the healthcare system. I think we need to unlearn compulsory heterosexuality. We need to unlearn this thing that we're just going to assume everyone is straight, because that's not how it works. But we also need to unlearn that everyone is cisgendered. Like, we just assume everyone is cisgendered, which is just not the truth. So I just feel like in terms of the healthcare system, we need to take those first few steps of unlearning these compulsory systems around the body and around sexuality. Because like you said, we exclude the trans community, we exclude so many communities, we exclude the queer community, bisexual people, gay people, all these people, because we're just assuming they're straight and they're cisgendered. And then, and I think it's hard, because when you assume these people, when you assume people are straight or cisgendered, you tend to exclude them from safe spaces and finding safe ways of recovery and health, which I know is something the trans community is struggling with a lot. It's like, who do I go to if I can't afford private spheres of health? But I think just one more thing, with the healthcare system, is that it just needs to be cheaper. Like, people need to be able to access healthcare. It's ridiculous that healthcare is so expensive. especially considering the rates of poverty in South Africa. It makes no sense for healthcare to be this expensive. And then, because then it brings up tough questions about what about poor queer people? Where do they go? You know? So it's just like the healthcare system just needs to unlearn a lot of patriarchal and cis heteronormative ideals, and capitalist ideals, because then they exclude a lot of people from accessing health and welfare, you know?
Yeah, I mean, if you go, you can use, I mean, South Africa offers government-sponsored transitions, but the waiting list for that, there's one surgeon in the country who does both top and bottom surgery, and the waiting list for that surgeon, they do 2 surgeries a year because of the way Groote Schuur schedules theatre time, and the waiting list is like 20 years long. Yes, Johan? Johan, you're muted.
Blonde moment. I actually read earlier this morning. It's now changed in Steve Biko in Pretoria. Our teaching hospital is now the only one offering it, and they're limiting it to 4 transitions a year.
Oh, I did not know that.
Because it was, I think we were like the only country in the world with government-sponsored transitions. But out of a population of almost 60 million, we do 4 a year.
I mean, like, what do you do with that? You're not, like, that, I'm sorry, that's not healthcare. That's not healthcare. You're not actually providing for what you say you're providing for. 4 transitions a year, 4 people a year is not adequate care. And the reason, like you said, the NGOs are filling the gaps in queer-friendly care is because the government isn't. It's not. And I think it can be considered really painful of the queer community. Like Shari said, queer people who live in poverty do not have access to safe healthcare, because if they go anywhere, they are subject to stigma and dehumanization, as you said. It's really disheartening, unfortunately, that queer people have to go through this.
Yeah, I mean, it places many queer people at risk. I mean, if people who want to, start their transition, all of that, yes, now it's available through the government if you want a lucky fall. But because it's so limited, people are resorting to unsafe practices as well. I mean, I've been in contact with students over the years who get hormones on the black market. They start their hormone therapy without any medical supervision. They, because it's so expensive, as Shari has said, you look for cheaper options. And there are sometimes life-threatening options.
Okay, so if before we end off on a really, really sad note, I just had one sort of question, and all panelists have like your sort of knowledge and you can add to this, but if there are queer students, high school or university, or young queer people who are not ready to speak to people about safe queer health, they don't want to visit a practitioner to learn anything, what resources can we give them to better know their health and to know their health better as a queer person if they don't want to speak to people about it specifically? Do we have any?
I see Pierre's asking you a question in the comments. But
cool.
Maybe Pierre can go first.
Thank you. I was just wondering if you wanted any input from us in the audience.
Yeah, no, input is always good.
Thank you. I was just reflecting, thank you all, by the way, for this fabulous discussion and presentation. I think I wanted to make a comment about what I call the violence of silence, by which I mean, as a queer man who's consulted health professionals over the years, how none of them has asked me, let me qualify that one is a cardiologist, the other one's a urologist. And both of them have the procedures have implications for your well-being and your sexual life and your emotional life. None of those practitioners have ever asked me over 10 or 15 years, do you have a partner? Are you in a relationship? Are you worried about the impact of these procedures on your sex life? And so it's not a kind of overt homophobia, although it is possible that they intuit that I'm gay and therefore they just don't want to say anything. Or maybe they don't ask any of their patients that stuff. And I just think that if health practitioners were enabled to feel comfortable, because you're seeing the patient as a whole person, you know, and it'd be so amazing if someone said, are you worried about the impact of bypass surgery on your sex life, for example? And the answer would be yeah. So yeah, that's a thought. Thank you very much.
Thank you for your input. I'm a human physiology student who wants to study medicine, and my sister's an artist, and she says, "Oh, you're such a humanities girl in the sciences." Often, and it's been said to me by more than one person, and I said, "But medicine is human. To treat people, to be in healthcare, it is fundamentally, it is science, but it is human. You are dealing with people and you must treat people as human." And I think so many healthcare professionals have divorced themselves to the pathology, to the point that you do not treat your patients as full human beings. And I think it's something that's really missing from not just queer healthcare, but all healthcare, to see your patients as full human beings makes healthcare more impactful and makes it more holistic. So yeah. Does anyone else have questions for the panelists or for me, or would like to just make some comments? You're welcome to. We still have some time if panelists want to add anything.
If I could maybe just say, I mean, part of the title of the session is also, you know, the future of sex education. And, you know, there are positive developments, and I'm happy to say that the centre, as part of it, is around the rollout of comprehensive sexualities education, you know, in public or in schools in South Africa. And I mean, there was a lot of negative publicity around it last year, saying that we're going to be teaching 8-year-olds how to masturbate, and it's all about lesbian relationships in the case studies and all that. But I mean, that was all misinformation, you know, and the conservatives in South Africa are supported by the evangelicals in the US. But it is being rolled out, and it is good stuff. It does teach about same-sex love. It teaches you about your body and how it functions. Ideally, I mean, you know, on paper, it looks good. We hope to be soon embarking on a process where we're going to be rolling it out to pre-service teachers. When you get a teaching qualification, you will be taught how to teach comprehensive sexuality education, and it's a full scope of human sexuality.
That's awesome. Thank you so much. That is good news. I'd just like to add that, and I will get, I have I've started collecting YouTube videos on gender identity and queer sexual health, and I added to the collection, but the collection was actually given to me by a friend. And so I'm going to ask our social medias officer, Andrea, to post that to the links to that on our socials, on our link tree, just for anyone who wants online resources. And if anyone else wants access to more information, obviously, as Johan says, you're welcome to contact him. But Johan, I hope we can add your slides. And Shari, you wanted to add something?
Yeah, I just wanted to add one more thing was I feel like a big part of sex education, yes, is talking about sex. But I think another thing, especially within the queer community, is that we tend to overlook the asexual community. And I think we need to normalize that not having sex is also okay, and not wanting to have sex is also okay. Because in the earlier this year, before lockdown happened, someone from my university just was asking me, because I'm part of Activate, they were asking me, is it normal that I don't like sex? And they thought they were strange because they didn't like sex and they didn't like having sex. And it's so upsetting because there are so many people, asexual people, who are forcing themselves to have sex because we live in a highly sexualized society, you know, and so they think that not wanting to have sex makes them strange. And I think as much, it's just as important to have that story with people who are having sex, and because we are advocating safe sex here. And I think it's also important to advocate that not wanting to have sex doesn't make someone abnormal, and that asexuality is a valid identity, you know?
No, definitely. And also that there are spectrums to asexuality. Asexuality is a little like gender non-binary. It's a being like not, or gender non-conforming, if you'd prefer to call it that. It is a spectrum. There are people that say that I don't want any pronouns, take the pronouns back. And there are people like, there are gender fluid people who say some days I feel a little more femme, some days I am in the middle, some days I want to use gender neutral pronouns, some days I don't. And there are asexual people who experience no desire. There are asexual people who partake in sex for other reasons, not just because they don't want to have sex. And so like normalizing the fact that desire is and sexual health it's not constant, and it fluctuates, and it can be affected by everything. And if you don't want to have sex, don't have sex. But yeah, so I think that was a really important point to bring up, so thank you. Does anyone else want to add anything or bring anything up? Do any of Johan?
There's an NGO specifically said, you used the example of a school learner who doesn't want to talk to anybody but needs resources. There's an organization that is run by a nurse, I think, called Safer Sexy. And they specifically do schools programs around comprehensive sexuality education. And I think they're on Facebook, and all of their details are on the CSA&G account. It's one of the accounts we like.
Okay.
I liked accounts. Safer Sexy, and they've got various toolkits and things for young people of different ages, which as a potential resource is also out there.
Thank you so much. There is also, this is not a South African-based NGO, but if we're talking about the fact that mental health is also part of sexual health, the NGO, the Trevor Project, has, I know there's not always access to, like, yes, if you're a university student, you obviously have access to UP&Out or other, depending on university, or Activate WITS if you're at WITS, or Rainbow UCT or other universities. But the Trevor Project has online chat forums for young queer youth that are moderated by licensed therapists. And you can have personal online chat forums with therapists if you need to talk to anyone as a mental health care provider as well. So there is that, if anyone specifically wants to talk about that. And then obviously if you're in South Africa and a part of UP, you have access to the CSA&G and Just Leaders, who offer free counseling and post-HIV counseling and everything else in between. Yes, Shari.
But I just found this out recently, but also in Johannesburg, the first queer wellness center opened up recently, and it's like, and I think they do everything from like surgeries to like mental health resources. So I can send you the number, Michaela, because I contacted them the other day. The only problem is that they're based in Sandton, but
Of course.
yeah. Yeah. But it's the first queer wellness center to open up in Johannesburg. So yeah, they're really helpful in terms of like everything from mental health to transitioning to just like, you know, all of it. Yeah.
Yeah. Okay. Thank you so much. I'd just like to thank everyone for being here, for speaking. I'd like to thank our panelists for your awesome input, for your time, for your thoughts, for everything that I'd like to thank that you've put into this and the energy and the time that you guys have sacrificed. We're really grateful for it up and out. We hope you have a fantastic Pride Month and an awesome weekend and week. I just see here from Pierre just before we end off, he says the WITS RHI has 4 clinics in South Africa for trans and HIV work, and it's free. One is in Bram. So thank you so much for that, Pierre. We'll hope maybe do some research. We're hoping to do some research and add that to our socials. So thank you so much. Thank you so much to our panelists, Vuyisa. Thank you to Shari. Thank you, Johan. We really appreciate your time and all the knowledge you've shared with us. So thank you.
You're welcome.
Thank you, Michaela.
I hope everyone has a lovely afternoon and an awesome weekend. Happy Pride, everybody. Bye.